First of all, I'd like to welcome all of you. My name is David Mark, and I am the chair of the Department of Health Informatics and Information Management here at the College of St. Scholastica. It's great to see you all virtually. It would be better to see you in person, but this will do for now. On behalf of the department and the college, I welcome you all to the 2020 LaTour Eichenwald Forum on Health Informatics and Information Management Leadership and Innovation. This forum did start as a way to welcome healthcare leaders to the college to share their insights and experiences regarding the paths that have led us to where we are today as a profession and in terms of the healthcare sector, as well as how we've gotten here in terms of our focus in healthcare at the college and within even our communities. To begin, I would like to welcome President McDonald to the podium, the virtual podium, to welcome all of you today to the forum. President McDonald?
Got to hit that mute button. Sorry about that, David. Greetings to all of you from the College of St. Scholastica. We're just really happy to have you all join us this evening for the LaTour Eichenwald Forum and to hear from Jim and all he has to share this evening with us. With his background and experience, where I think we're very, very lucky and honored to have him here presenting to us this evening. I just want to also give my deepest thanks to Kathleen LaTour and Shirley Eichenwald Mackey for their inspiration and their leadership and getting this whole thing off the ground, and really appreciate everything that they've given to the college to make this happen. So we just want to make sure to recognize them tonight as well. So I'm looking forward to hearing from you, Jim, and all you have to share tonight, and especially as we as a world are facing so many challenges when it comes to healthcare. So welcome to all of you, and I also would like to wish you all very happy holidays and happy Thanksgiving and Merry Christmas. And I hope all of you stay safe and well, and as you enjoy the holidays ahead. So I'll turn it back over to you, David. Thank you very much for having me tonight.
Thank you. So Kathy LaTour and Shirley Eichenwald Mackey, they spent their careers at the College of St. Scholastica advancing the profession and the health information management profession through education, their leadership, research, and collaboration. And they really took HIM to the next level and are recognized pioneers. And to highlight some of their notable achievements, they developed the first accredited MSHIM program in the country. They wrote the textbook on HIM, which you can see tucked behind in that picture there. And now that textbook was passed on to co-editors who are faculty at the college, Pam Oakes and Amy Waters. It's now in its 6th edition. And after all of that and really putting the college on the map for our role in health informatics and information management, they retired in 2012. And in honor of their pioneering spirits, the college has established the LaTour Eichenwald Forum on HIM leadership and innovation. And our guest today really embodies those leadership qualities and the innovative approaches that Kathy and Shirley have always demonstrated. I would like to take the time to recognize Kathy LaTour, and if she's on, to have her wave her hand if she's on the call here right now. There's a lot of names.
I'm on, David.
All right, thank you, Kathy.
Good to see everyone.
As well. And as we celebrate Kathy and Shirley's achievements, we also reflect on the wonderful life that was lived by Shirley. Shirley did pass away in 2019, and this forum is one way for us to celebrate the great life that she lived in all of her contributions. And to commemorate Shirley, we did have last year, we had a special memorial made in remembrance of Shirley, and you can find this memorial. It's at the college on campus. It's sitting in our, we have it on display inside our department, and on the first floor of science. And the plaque reads, as you can see, the Department of Health Informatics and Information Management, Shirley Eichenwald Mackey, in loving memory of our leader, teacher, mentor, and friend. So let's just take a moment of silence in remembrance of Shirley Eichenwald Mackey and all that she contributed to the profession and our lives. Thank you. Today, I am very happy to welcome Jimmy Kolker to the college and to share his thoughts and experiences on innovation and leadership with regards to global healthcare efforts. And the way this is formatted today is we're going to hear remarks from Mr. Kolker with time for questions at the end. And that way we can engage in some meaningful discussion following his remarks. We'll ask that you keep all your microphones muted until the end of the presentation. At that point, feel free to unmute yourself to ask your questions. And you also can type in your questions into the chat and we will read them to Mr. Kolker as well. If it's too disruptive, we might just switch fully to the chat, but we'll see how it goes. So I'm happy to introduce our speaker, Jimmy Kolker, who is an American diplomat. He graduated with a BA in magna cum laude from Carleton College here in Minnesota and received the Thomas J. Watson Fellowship in 1970 and 71, which allowed him to spend time in Chad, Uganda, and Ghana. And Ambassador Kolker earned a master's in public administration from Harvard in 1983. He joined the U.S. Foreign Service in 1977 and held diplomatic reporting posts in Mozambique, Zimbabwe, Sweden, and the United Kingdom. He then moved on to management jobs as the Deputy Chief of Mission at the American Embassy in Botswana from 90 to 94, and in Copenhagen, Denmark from 96 to 99. He was the ambassador to Burkina Faso from 99 to 2002 after being nominated by President Bill Clinton, and a U.S. ambassador in Uganda from 2002 to 2005 after being nominated by President George W. Bush. From 2005 to 2007, Ambassador Kolker was Deputy U.S. Global AIDS Coordinator, leading implementations of the President's Emergency Plan for AIDS Relief. He was Chief of the HIV/AIDS section at UNICEF's New York headquarters from 2007 and 2011. And then from that point until 2017, Ambassador Kolker was the Assistant Secretary for Global Affairs with the U.S. Department of Health and Human Services in Washington, D.C. Ambassador Kolker represented the HHS at interagency and World Health Organization meetings, and his office had led leading roles in global health security. He also is an alternate U.S. board member of the Global Funds to Fight AIDS, TB, and malaria. Now retired. After that exhaustive career, Mr. Kolker serves on boards for Mana Nutrition, the G4 Global Servants Alliance, Building Tomorrow and Firelight Foundation. He is a visiting scholar at Georgetown University Center for Global Health and Security, at the Center for Strategy and International Studies. He's an advisor to Last Mile Health and to Texas Children's Hospital Global Hope Pediatric Cancer Initiative. And he also is associated with the Transnational Strategy Group, LLC, a Washington-based consulting firm. Ambassador Kolker has had a significant contributions to global health efforts, and we are very excited to hear more about his experience as a leader in this space. Let's extend a warm virtual welcome to Ambassador Kolker.
Thanks so much. It's really a pleasure to be with you and a treat. I can first thank President McDonald and honor Kathy LaTour. I'm of the generation where being known by one's children's accomplishments is the ultimate joy in life. And it's Annie LaTour Schwartz who connected me to this forum and to the work of yours, Kathy, and Shirley Eichenwald Mackey. And it's great to be part of that family and to be back in Minnesota, even if virtually. I have been to Duluth in winter, so I can imagine what things are going through, and I may be in the minority, but I regret not being there in person at the end of November. So thanks very much for having me, and I look forward to the conversation, questions, and your comments afterwards. I am going to present some PowerPoint slides and talk a little bit about my observations as a person trying to bridge the science and diplomacy priorities these days. And let's see if that screen share works. There we are. Anyway, this this is how diplomats and policymakers use or don't use data and evidence when making decisions about public health programs. And this is a little bit of a table of contents, talk about science and diplomacy, about the paradigm of global health, which I think is changing. Some examples from my own career about AIDS, Ebola, Zika, and COVID, and then maybe some thoughts on health information management and lessons learned. First, there really are two cultures. I think scientists approach a problem to solve it. They see an anomaly or a pattern, and they do research. And if the if the evidence is strong enough, they publish in a peer-reviewed journal, and they've solved the problem. But diplomats, if we're good at our jobs, and most of us are, put our priorities onto other people's agendas. And that means understanding the words there. Whether, is this a priority? We may be solving a problem that actually isn't a priority in Uganda or wherever we're located. Who are these other people and what are their agendas? So diplomats need to be able to use the information that scientists develop, but to understand and incorporate that data and evidence in their own persuasive arguments and decisions. And the scientists therefore need to be able to present that information in ways that's accessible to non-scientists, because as you know, whether data is singular or plural, it rarely speaks for itself. We need to figure out, why is this information important and how can it be used? The methods are different too. The scientists are methodical, go where the data leads. There's often no timetable for a research project. And every article in a peer-reviewed journal starts with uncertainty. We need more research needs to be done. We have, here's what the evidence shows, but there are many things we don't know. But diplomats read the paper in the morning, or they see an outbreak, and they are, as CDC describes it, outbreak dependent. We have to get just-in-time information about what's going on before our eyes and to minimize that uncertainty. And many times a scientist or a health professional will say, oh, well, we know the answer to this problem. We know what to do about this disease or this condition, but we lack the political will to accomplish it. And I guess my main point to you is that political will isn't a light switch that you can turn on and off. Political will can be built by effectively using the evidence and the research that you're doing, the information that you're developing, whether it's at a hospital or in local government or on a national scale, to inform the politicians who have to make the decision makers, diplomats, to say, here's why this is important to you and why it actually will help you solve the problems that you're looking for. I also want to talk a little bit about the paradigm about global health. There's an old-fashioned model, and I think that St. Scholastica, if I understand your program right, is beyond this. So this is not what you're doing, but this is the mindset for which many people involved in what used to be called tropical diseases or international health, and now is even more often referred to as health security. But here's the tropical disease paradigm, that people from developed countries are providing health services for infectious diseases for local populations. And the researchers from developed countries, US and European universities, find local research partners, but have already got the grant for their own research. And the idea is that donors would be providing small programs that would be a proof of concept or a pilot study or a center of excellence in a recipient country. And that from the data point of view, and I've highlighted and read some of the things that I hope will be important to health information managers and people looking at that as a career, that much of the data that's collected was for accountability to the funder. Was the money spent properly? What are the outputs of the pilot study? Not necessarily, is this sustainable, or how will this actually make the local system perform better? There is a new paradigm, which I am glad that you're embracing, which is, I know that probably many of your students are already international students. There's now a critical mass of qualified nationals to do basic public health work and patient care in almost every country. And the low and middle income countries want partnerships with institutions in the US and other developed countries, because they want the world's best experts to bring their own health systems and practices, their own human capacity to first world standards. And this is true not just for infectious diseases, but the whole changing disease burden, the question of chronic and non-communicable diseases, which now are the leading cause of death in almost every country in the world, not just developed countries. And at the same time, the country needs to own its health response. These are programs that need to be sustainable, that need to be accessible to their populations, need to be afforded in their own budgets. They can't be dependent from one-off donor participation in trying to assure that what's now the goal of universal health coverage and a huge number of sustainable development goals, for which just the health goal has 17 different indicators which countries are going to be trying to meet. There also is very much in your line of work, emphasis on outcomes and measurability. These sustainable development goals all have indicators that need to be reported, and a health ministry has to make an investment case to the finance ministry or to donors or to foundations or to multilateral organizations like the World Health Organization or the Global Fund, that what they're doing is actually going to achieve the goals for which those organizations are investing their resources. And finally, as we know now, a little bit too late, that preparing for outbreaks, epidemics, and for bioterrorism need to be an integral part of building health systems. And some have done that much better than others using the metrics that they are collecting already, but some have not used those metrics very effectively. And I fear that our own country is in that category. Let me talk briefly about a couple examples from my own diplomatic career. If you were HIV positive in the United States anytime after 1996, you were very likely to get a 3-drug combination that reduced your immune deficiency, reduced opportunistic infections, and HIV positive people were able to live largely normal lives. But many suffered severe side effects. These drugs were administered under strict medical supervision of a specialist doctor with periodic viral load tests that cost about $1,000 per test every quarter. And the drugs themselves were about $10,000 per year. And there were no long-term studies of patient outcomes. As you know, if you're trying a new drug, you would want a cohort study to say, well, what's the effect going to be 10 years from now? Is it really safe, or are there going to be unexpected negative incidents? But the drugs were very effective, and certainly keeping people alive was a priority for the US and was quite a breakthrough back in the late 90s. But I was ambassador to Uganda at the time, and this was dealing with scientific uncertainty. There were a lot of things we didn't know. Patients were in isolated locations, didn't have access to tertiary medical centers. Many of them had stopped eating. Their illness meant that they were undernourished, didn't have access to good diet. There were no specialists available, very few trained doctors, even nurses who could provide monitoring or administer their care. Not in the habit of taking multiple pills at precise times. And the early AIDS drugs were required a number of different medications to be taken at different times during the day. It would be difficult to know what the side effects were, whether they were caused by the drugs, whether the treatment was successful, because these people were not routinely under specialist medical care. And there was no African government except Botswana that had the money to provide drugs at the time. In Uganda in 2003, when the President Bush announced his emergency plan for AIDS relief, and I was ambassador there were nonetheless about 50,000 HIV positive people who already were enrolled in care, but they were not getting the antiretroviral drugs that would actually save their lives. And it turned out that our fears about all of these uncertainties were not what happened, that actually the medications worked probably even better in Africa because the people were naive to treatment. They had not been trying other potential treatments up to then, and did have the miraculous recovery that justified the risks in giving people drugs for which we didn't know the long-term outcomes or effectiveness. As a health information challenge, though, this was a particularly good case study because, as Annie LaTour knows very well, she was at the cutting edge of this. We had lots of numeric goals and reporting requirements. And we were working together in the Office of the Global AIDS Coordinator, the third and fourth years of the PEPFAR program. But when I was in Uganda, the health information system that they had covered only public facilities where only about half patients got their treatment anyway. The data was very unreliable. Every hospital, every clinic had its own way of reporting or not reporting what was happening. Their observations about the symptoms and causes were not standardized. And so the question of to what extent was the data that we had useful in providing what was not a pilot program or a proof of concept, but national scale up, in which we were going to try to reach at least all those 50,000 during the first couple of years, but everyone in Uganda who were in the hundreds of thousands who was HIV positive and could benefit from that care. And so as part of the PEPFAR program in Uganda, we actually recognized that health information was a crucial component, that the status quo wasn't acceptable. And there was a $2 million contract availability to solve that problem, I should put it that way. And the contract there were a couple of bidders, but the contract went to the one that had the shiniest, most dazzling new object. There was going to be a state-of-the-art system that would give the Uganda Ministry of Health all the information that at least the US government needed to scale up the program and figure out what our impact was. The system turned out to be a total failure. It actually had to be replaced after I left. I admit that failure. The providers were used to a paper-based system. They didn't change their habits. They didn't have time to. With the new drugs, they were in more stress than they had been before. There was a huge shortage of qualified healthcare workers. The work stream just became an impossible burden, so that the information that was reported was either inaccurate or insufficient or not at all. And what was important to know was that there was no ownership of this system by the people who actually had to input the data or provide the care to which this was presumably being the information base for improvement. So a huge lesson learned that our program was much handicapped in the early years by the fact that even though we were able to scale up the treatment and we were saving a lot of lives, we actually were not able to demonstrate exactly what we were doing because the health information system wasn't adapted to the needs of the people who were benefiting from it or were having to use it. Ebola was a much different kind of challenge. This was an emergency response. It was not a chronic disease. People who had Ebola either died or recovered from it within a few weeks. But there was a failure of international coordination. The World Health Organization was not able to help the 3 West African governments that were affected. And the question of the world was looking for the US to lead, but we inside the government at the time, and then by that time I was at the Department of Health and Human Services as head of the international programs. And what were our interests? Ebola was not, in fact, a great threat to the US homeland, although we were quite worried about it and took precautions. It was centered in 3 countries in which the US had pretty marginal interests. And the way in which we could help, our specific comparative advantage was the logistics that the US military could provide in bringing Ebola treatment centers to the places where there were none. And the military was exceptionally reluctant, that's an understatement, to take on this new role when they were being triply deployed in Iraq or Afghanistan at the time. So what, we're flying tents to Liberia? This was not their core mission. And then in order to get health workers to staff those treatment centers, there had to be an assurance of a kind of high standard of care, at least for the healthcare workers if they got sick, and both Liberian and foreign. And the obvious answer to that was the US Public Health Service staffing a field hospital outside of Monrovia. But the diplomatic challenges of this were that this was unprecedented. The US doesn't staff hospitals overseas as a main job, and certainly not on an emergency basis. And there were about 6,000 people in the US Public Health Service, but they all have day jobs, and they are the main providers of healthcare for the US prisons, for the Indian Health Service, Many of them work at CDC and NIH and other US government essential services. So the first question was who could go? And to our delight, it was on Labor Day weekend that they sent out a message to the 6,000 public health service people. And by Tuesday, 1,000 of them had volunteered to go to Liberia. So that was encouraging. But these people had no right to practice medicine, to prescribe drugs in Liberia. What's the standard of care? These were not Ebola specialists. We'd had none of them had ever seen an Ebola case to treat. Where would they get the training? How would that be connected to the facility they'd be going into? And then who would provide security, housing, water, transportation, all of the things you need to actually get a healthcare facility up and running. And then the question of on what basis would they judge who had access to this facility? Who is a healthcare worker? With probably the person who cleaned the floor of the health facility should qualify, because that person clearly was exposed to Ebola in the course of his work. But what about the person who kept the budget for the NGO that ran the facility and lived in the capital? What if it's a US citizen who was there but didn't have Ebola symptoms but saw there was a high-class facility with American practitioners there? What about the CNN reporter with the cameras running, coming to the gate of the US taxpayer-funded facility and saying, I need care here? So there were a huge number of procedural questions which US health information managers and health systems experts realize go into providing or opening or providing care in a facility. And it was up to my office and to the embassy in Monrovia to actually answer those questions. And we were able to check in the end all of the boxes that needed to be checked to be able to get that facility up and running. The third example from my time in government was Zika. This, as you remember, was a virus that was in Brazil that had unexpected consequences in terms of birth defects. And Brazil had a pretty sophisticated health system, but we were trying to be involved. We needed sample sharing for our own blood safety tests, as they did. They did not have a good blood screener, blood diagnostic. There was very promising vaccine candidates based on chikungunya and dengue, which are related outbreaks. And the CDC did have a cohort ready to study the birth defects and supplement what the Brazilians were already doing. But all of these were held up by political decisions in the Brazilian Ministry of Health that didn't want to admit that they were not at the cutting edge of all of these ideas, and that they didn't want to look dependent on the US for help. So we did end up sending a delegation, which included people from all of the main US government health agencies, and who met with their Brazilian counterparts over 2 days. And I co-chaired the meeting with the Brazilian Minister of Health. And we came up with a 14-point matrix of who would be responsible for each of these areas of cooperation. And this, by getting political approval in advance for this cooperation, the cooperation could then take place among scientists and practitioners. And it turned out that about 6 weeks later, the Brazilian government disintegrated. But this matrix held, and the level of technical cooperation continued, even though the diplomats no longer needed to be involved. This was simply a framework agreement that allowed the technical people to get on with it. I think to start to talk about COVID-19 from the US government's point of view, we were fighting the last war. The Ebola legacy was that domestic preparedness was not tested. We had reformed and scaled up in response to Ebola, the instruments already in place, new functions and structures of the World Health Organization. There was binding international health regulations, which Guinea, Liberia, and Sierra Leone had not observed and were not prepared to implement. So we were strengthening those regulations and countries' ability to fulfill them. We had a US government-led program called the Global Health Security Agenda, which about 60 countries signed up to help their own and other countries' preparedness. The G7 industrialized countries committed to helping low-income countries achieve those objectives. And we had a project on zoonotic infections, transmission from animals to people, that USAID is underway, that looked at things exactly like the COVID-19, the coronavirus in China. And I think it's worth talking a little bit about, again, the diplomatic framework in which health and health information needs to be considered. After the SARS outbreak in China, which China had mishandled from start to finish, it's concealing information, failing to share data even within their own health system. They established the Centers for Disease Control, which was modeled on the US CDC model. They invited the US CDC to be co-located at the Chinese CDC facility, which is about an hour away from the embassy in Beijing, so not on the embassy compound, but co-located at the Chinese CDC. In 2013, there was an outbreak of bird flu H7N9, which people thought could become the next big epidemic. It did not. Around 40 CDC experts surged to China, helped the Chinese themselves track this down, did the surveillance, did the control, were able to isolate it and control that within China. It did not, you probably haven't heard about H7N9 because it did not become a global pandemic. And then when Ebola broke out, the Chinese actually went to Liberia as well and worked with US operation there. And we worked together in helping to establish an Africa Centers for Disease Control based in Addis Ababa. There were also, when I left government, 3 bilateral agreements on information sharing with China, between 1 CDC to CDC and 2 from our Department of Health and Human Services to the Ministry of Health. Unfortunately, after 2016, because of the fallout from Benghazi, all US government employees were supposed to move to the embassy compound. We had been dragging our feet about CDC moving, but that was accomplished in 2017. And we're also, because of tensions with China, told to reduce our footprint in China. And so the CDC staff, US and Chinese, was reduced over between 2016 and the outbreak of COVID to from 47 people to 14. And the 3 bilateral agreements all expired without being renewed. And I guess from a health information point of view, in China and many other countries, you need an umbrella agreement. Working level employees there are afraid of sharing data, need an authorization, because sharing information, clinical information or statistics from their facilities are considered privileged information, and it's a very hierarchical structure. So in order to share, for instance, with another country, especially the United States, they needed to justify that. And these 3 agreements did not require the sharing of that information, but they did authorize it. And so the fact that there were no agreements by the time the coronavirus broke out meant that we were severely handicapped in the what would have been obviously in the world's interest in the Chinese being very forthcoming and sharing the information about their early cases. But that did not take place, in part because individual holders of that data did not felt they were taking a risk in sharing it, and that they were safer not sharing it, letting it go through very hierarchical structures. So were we prepared in the United States? We did have, even though the directorate at the National Security Council in the White House on global health security and biodefense, which had been established in 2016, was moved, and the staff moved to the Weapons of Mass Destruction office in the White House. We did have 2 valid strategies: National Biodefense Strategy and National Health Security Strategy. And these both included informatics and information components. But we didn't really have our grip on how to deal with low probability, high consequence events. We thought of a pandemic, because we hadn't had one really in a century, of being like an asteroid. And yes, there's a 5% chance that between now and 2095, an asteroid will impact the Earth, and our way of life as we know it will be dramatically changed. But none of us is living our daily lives preparing for an asteroid or in fear of an asteroid hitting. And yes, we're paying a few experts to follow this in space, but our government isn't making a priority preparedness for an asteroid impact. On the other hand, we are working every day as a government on terrorism. And terrorism has killed about in the tens of thousands of people per year. Almost none of those were in the United States, a couple hundred per year since 9/11, since 2001. It's been only in the hundreds the people in the United States who were victims, almost all of them in the Middle East, Africa, or South Asia. Nonetheless, 42% of Americans said they were worried or very worried about themselves or a family member being a victim of a terrorist attack. And the statistics are oddly parallel for disease outbreaks. There were 119 outbreaks of infectious diseases that were deemed significant by the WHO. The deaths are also routinely in the tens of thousands per year. But we allowed the money that had been appropriated for the Ebola response to expire, and we're spending about less than 1/10 as much in preparing for a disease outbreak as we were for a terrorist attack, in airport security and intelligence sharing and military work abroad and working with other countries. The threat from terrorism to the mainland homeland was about the same as from disease outbreaks. We took the terrorism threat so much more seriously. You could say, but the US was the best prepared country in the world. And this is where I want you people who are involved in health information, you've got to look at the statistics in a granular way. If you look at, yes, we got high scores in most of these things, but if you look at where we got failing grades, health capacity in clinics, hospitals, and community care centers, medical countermeasures, personnel deployment, healthcare access, we have a 25 out of 100 grade. And then on the left-hand column, if you look at exercising response plans, every military person knows you have to exercise what you're going to do. We had 0. Our teams just had never worked together, did not know each other, met for the first time once we had a crisis. So you need to keep the statistics. Finally, for health information management, I just put together some random thoughts about that would be relevant to this forum, but I welcome your improvements and further thoughts. We underestimated so much of what would be needed, which could be quantified in terms of bed capacity, supply chain, the geographic and ethnic diversity of the at-risk population, and the importance of who is giving messages and how often. We thought that because we had medical training for dealing with an outbreak, that we were prepared. But we really underestimated the sociological, economic, and ethical issues, as well as biomedical in terms of our preparedness. And these aren't vague things. Many of them actually can be quantified, and there are lessons that we can learn from the health information area in terms of bringing those into our calculations. Also, it turns out that we were collecting data mostly at the state level, but what we needed was site level information. And this is true across the global health field, that the granularity of the information is exceptionally important. And that the fact that we knew how many beds each state had didn't make that much difference if you were in Duluth and the beds were at the Mayo Clinic. And so this question of who's collecting the data for what purpose, what are you anticipating, we've learned from COVID, it really needs to be looked at from a much more operational point of view and with much better site level data. And then, yes, we could improve survival rates, but we weren't really very good at collecting and analyzing the data on who survived and what interventions they'd had. There were so many false starts in terms of hydroxychloroquine or remdesivir or intubation, oxygen, ventilators. We were getting all sorts of conflicting information about what actually was working, and it was facility by facility where they used this information for quality improvement. And the survival rate is much greater now, but it wasn't because we at the state or national level actually knew that. It was each facility discovering by using their own data and to some extent by trial and error what was working. And so again, the health information aspect of this is really crucial, and we didn't use it very well. And finally, as you know, we changed the data reporting requirements midstream during the COVID outbreak, replacing the CDC system and linked to hospitals with a different system. And I think many of the initial results, at least the first couple of months of results, were that there were no incentives to actually meet the more stringent requirements that were being imposed by the new system. And there were incentives to falsify the data in order to say that you'd met the criteria that were being imposed on the states, the localities, and the hospitals and clinics. And so the value of having a reporting system that the reporters themselves own, understand, and feel is valuable was reinforced by this idea that changing the system midstream to something that would serve the decision makers better was actually counterproductive. Just like in Uganda in 2005, we had a perfect system except that no one was willing to use it, and so the data that we collected was useless. So just mention one more thing, because we're all interested in vaccines and there's been a lot. The competition is intense. We have, as for vaccines and for treatments, we're very lucky that we now have effectiveness data on the two nucleic acid vaccine candidates, but the barriers to access by people in low and middle income countries and even perhaps disadvantaged groups in the United States are that this is going to have, there's going to be a patent on this, on these vaccines. They'll have intellectual property. Internationally, there is sovereignty. The countries that have reserved supplies for their own population, as we in European countries have of these vaccines. High costs because of those two things. Logistics, cold chains, two-dose, how to deal with a vaccine that requires 2 doses and not give a false sense of confidence after the first one. And the fact that there'll be a finite supply by the first month of manufacture after FDA approval, there'll probably be about 40 million doses of these vaccines available in the United States. And that's great. That's 20 million people who can get protection. But of course, that's a fraction. That's what, 6-7% of the population who might ultimately benefit from that. And all of the initial doses that do require this cold chain have been bought up by the United States and the European Union. So the idea that this is going to go to countries where hotspots in India and Brazil and other places, so far there is no likelihood that these two first promising candidates will be supplied anywhere outside of the richest countries. And the international system has taken actions, but the US hasn't been involved in them. And the so-called ACT Accelerator Access to Coronavirus tools that with the COVAX as the vaccine arm of that is underway. They have about $2 billion in pledges, but at the moment they don't have access to either of those two vaccines. And the US, both in the public sector through National Institutes of Health and through the private sector in our innovative research pharmaceutical sector, is responsible for about 50% of biomedical research funds in the world. And so to have a global scale up without the United States directly involved in the discussions is going to be a disconnect, and I would call it a train wreck. And this is the most consequential global health governance challenge of our time, and the US simply isn't there. And I think certainly the President-elect Biden has talked about re-engaging, but this train is already on the track, and it's going to be much more challenging than I think anyone has ever been through before to see how we're going to get the vaccines to people, both in the US and abroad. I'll leave you with some questions for your own discussion. With the site-specific granular health information, how do you, or the academics and the experts in this, improve our data knowledge and use within individual hospitals, laboratory? What are the quality improvement systems that data can drive, or that health information management can drive? And how then is that scaled up? If you come up with a better solution, how do you get your whole community of health information managers to recognize that this is worthwhile? Because clearly not every facility can collect data in its own way or report it in its own way. It has to be standardized and presented to policymakers. And then something that we learned, and we've learned again in coronavirus, that solving the problem technically may not actually deal with the cause of the problem, that it's about a relationship, it's about the people who are involved in bringing about that solution. It's not just about the problem itself. And finally, because when I went to college, there was no such thing as an AIDS diplomat or a health diplomat. It's a career that didn't exist yet. And you're now have to think about what are these careers that don't exist yet, and how is your education at St. Scholastica or in the courses of study that you're going to be pursuing, how do those prepare you for those careers that don't yet exist? What are the skills you're going to need to use what you know now and apply it to problems that we can't even imagine today? So with those challenges, I look forward to the discussion.
Thank you so much. That was very interesting. So if you do have any questions, please feel free to unmute your microphone or answer some of these questions, respond to what's on the screen here. Also, you can type into the chat window as well to ask questions, respond to these prompts. There is one in the chat here that I do want to bring up. It says, many HIM professionals voiced concern about the COVID-19 mandatory data reporting okay, sorry, let me read that again. Many HIM professionals voiced concerns about the COVID-19 mandatory data reporting rather suddenly being taken away from the CDC and directed to HHS. Should we have concerns about this change in reporting?
Well, I alluded to that, and of course, I'm not in government and I don't know all of the background or the consequences of that change, but my short answer to that is yes. We should be concerned about that change for a number of reasons. One is that starting a new system in the middle of an epidemic is going to be disruptive to people who have a ton of responsibilities, and that any change is going to mean that the quality of data and the attitudes of the people who report it is going to be in question. You can't be assured that this is just going to go on seamlessly in a transition. The second is, have they taken into account the incentives for the people who are reporting the data? And I think what we know now is that they didn't, and that there have been there are incentives to falsify the data or give a rosier picture of what the results are in the new system compared to the old one, which was at least pretty familiar to the people who were required to do the reporting. And I guess the third one is, for what purpose is the data being used? And I don't think that's been clearly communicated either to the people who have to collect it, or do they have access to it? If you're in a hospital in an intensive care unit or as the health information manager, when are you going to get that data back to know what that means in terms of, are you going to get priority access to PPE? Is there surge capacity in terms of staff or budget or any equipment that you will get based on your reporting of that information? And certainly what's been in the press is that has not been aligned. And so again, the incentives to report accurately and the use of the data for optimal patient outcomes seems to be lacking. So I'd love to hear your point of view as professionals in that area, but as a policymaker, this was not a successful use of health information management to achieve a policy end, I would say.
Another question is, do you have a sense of how uniform the reporting is or is not across countries? How confident can we be about the global COVID data?
Yeah, I'm going to throw that question back to you, because what I've read in the press, and I am in contact with a couple of people who were actually involved in that part of CDC, who did not think this change was justified, but they may have a vested interest, is that the quality of the data, the actual amounts of data, they were asking for more information, that the number of people who filled out even the questionnaire at all or filled out the additional information was a smaller number than had under the original system, and that the data was not particularly well used by the task force or by HHS in prioritizing, for instance, that stockpile distribution of equipment or trying to track the cases and giving specific guidance, site-specific basis. But again, I'm not on the inside of that. This is just from publicly available information and from people who may have a grudge.
Related to the sharing of data, what do you feel like, and even with your prior experience, practices that have worked, are ways to mitigate the trepidation of sharing international health data?
Yeah, I mean, we do need standards. We can't just make up what we want to report. And we can't say to the Chinese, it's up to you what you want to share with the rest of the world. There's some standards of the sequencing of the giving access to samples and so on, which they did not fulfill. And I think we were right in holding the Chinese to a higher standard, and the WHO is the instrument by which we do that. So having worked with the WHO, it's a very imperfect organization. I don't think they're at fault. We, the US, also did not share all the information we had when we had it with the public or with practitioners or with state health departments who might have been able to take earlier action just on our own preparedness and response. So it's hard to kind of put this into a box and say, oh, there's a right way to do it. And I guess my experience from being a policy person looking at what we need from the health system, the idea that facilities themselves see what's important to their own care improvement. How can they get better use of their personnel? How can they make better use of their budgets, better use of their facilities? And talking to getting the whole facility involved. What information do we need to make those judgments? Who needs to have that information? And on what can we reasonably expect that the people collecting it can report? And then the health information manager really setting up a system that's going to help the facility itself, but also meet the international, national, state, and other standards that do have to be harmonized. I mean, the problem of the initial COVID test that CDC developed, this is a novel virus, and they were worried that if they allowed just commercial manufacturers to each get a diagnostic and put it on the market, that we wouldn't even know after we had results from 7 different kinds of diagnostics what those results were, that they weren't directly comparable. So having a national standard of one test that everyone should rely on was the right first idea. But when that didn't work, the idea that we were still insisting on everyone giving the same test for which we had garbage data, and the test clearly was contaminated in some of its functions, meant that the people responsible for wanting to get the results of those tests should have quickly regrouped and said, what is it we want out of this? Yes, we of course we want a perfect test, but we don't have it, and what's plan B, because time is wasting. So it's, I guess, again, you have people who really do know the right answers, but are we going to be able, as a diplomat has to do, are we going to be able to put those on other people's agendas and persuade them that they need to take action based on that information?
So do you feel like getting the US back into the World Health Organization is essential to being in a position to advocate for those data standards?
Yeah, I think a lot of people misunderstand about international organizations. I mean, the World Health Organization is from 1948. It was the first UN technical agency. It's a dysfunctional model. Its governance structure is all of the health ministers from every country in the world meeting for 10 days in Geneva to come to consensus decisions. Now, just the idea that every country in the world was going to have a cabinet member stay in Geneva for 10 days, and then that we would be able to reach consensus on everything just isn't happening. That doesn't happen. So, but WHO therefore has to be, I mean, it's a member state political organization, and the head of it's elected by the member states. So yes, there are sensitivities. The WHO is not going to accomplish much by confronting China, or for that matter, confronting the US. They're probably more sensitive to how the US will react to different decisions or statements they make than even China. But so WHO needs the support of its member states. It has a budget. I should have checked this for Minnesota, but the WHO budget is 1/6 of the Maryland State Department of Health. It is not funding programs or care. It is giving technical support and writing norms and standards. And its data collection is very important. So the idea that health information managers need to understand what are the indicators on which the WHO is requiring countries to report data, to collect data, is part of your life. And they do generally a pretty good job of that. I think because it's so consensus driven, they're often behind the curve. but they've established some standards which countries do report on, and which the information to compare between countries or to judge against a standard like the Sustainable Development Goals. The WHO is the best we have, but it's a way for the US to leverage our influence and our budget. We are the most influential, or were when we were active, the most influential member of the World Health Organization. And both in terms of money and in terms of rules, do we have a rules-based, science-based world order that the Chinese and the Russians and the Iranians and others need to respect? The US was the enforcer of those rules. And if we don't have those rules, we don't have the science and WHO being respected or observed by anyone else, the people who benefit from that are the people who don't follow the rules, the Chinese, the Russians, pirates who are going to steal intellectual property and put their own drugs on the market, and irresponsible, I mean, really unethical corporations that are going to break the rules and make claims for their products or try to promote them in ways that are in violation of what we know to be best practice. So yes, I think the United States made a mistake in withdrawing. I think we should reverse that as soon as we can. But also there's a reason for that, that we need WHO to be stronger and we need it to be a respected organization. And there are plenty of weaknesses that if and when we do get back at that table, we need to be sure that they're going to do better in the next outbreak.
Another question. Was there a question that someone wanted to ask? I don't know if I'm cutting someone off.
You know, just on that question, if I can, I hate to put her on the spot, but Kathy's daughter, Annie LaTour Schwartz, you know, has been in Geneva, and I'd just be interested in her perspective on this, because she knows St. Scholastica and HIM, and she does know those multilateral organizations. Annie, can I call you out here?
Sure, thank you. Yeah, no, I totally agree that it's just very critical. I think just living in Geneva, we get very US centric in the US government, and we're very focused sometimes on our own internal politics. And when you're in Geneva, you realize that we are just a part of a bigger puzzle, and how important the US is on that stage and in that the cog in that wheel, and just to be at the table. So I just feel like it is critical.
And is it your sense that we're less able to leverage other countries to do what we think they should be doing because we're not in those organizations? That it's not a zero-sum game. It's not that if China has more influence, we have less, or vice versa, that actually we can use the organization to influence what China does in a way that we think would benefit both.
Absolutely. I mean, in the end, a lot of the work is done behind the scenes, and it's relationship building. And I think there's the politics you see in the news, but I think in reality, there's a lot of relationships. And if we're not at the table, that they just aren't happening. And then we're missing out on all this expertise.
Thank you, Annie. Another question that came in, political opinions aside, back in March into April, the government was stating they inherited a broken system in responding to COVID-19 or a similar sort of pandemic. Do you agree, based on your experiences with this assessment?
Yes, certainly the national stockpile was disgracefully undersupplied with the things that we needed for even initial response to an outbreak like this. And the idea that could be a flu or a coronavirus, which is related to the common cold. I mean, these aren't things that we could never have anticipated. And the idea that we had really invested in the national stockpile investments in the 3 years since I left government were in responses to bioterrorism. We had countermeasures for anthrax, for smallpox. If someone was to genetically engineer a pathogen to for an attack on the US or one of our allies in terms of a bioterrorist attack. That's where we were investing our money, and that's an important, we need that preparedness, we need that capacity, but emphasizing that and neglecting what was really the more likely low probability but high consequence event, which is a naturally occurring outbreak or like this, was a mistake. So yes, we were disgracefully underprepared. Whether that the Obama administration did not, I was part of the Obama administration as a political appointee in my last job. I've been a civil servant for all the rest of my career, but we did not pay attention to the stockpile. And the stockpile in my era was under the CDC. So at least there was a kind of public, and CDC were the people who were in contact with state and local health departments. So there was a kind of familiarity, at least with that mechanism. Just a year before the COVID outbreak, that stockpile's authority was moved under HHS from CDC in a political move similar to what was done with the information gathering. And that, I think, was part of the problem, that the states didn't really know what they could access, and it became politicized, and that some of the information, but in particular the equipment, was given on a basis that may not have been public health driven, but in terms of some politics. So politics aside, no, both administrations did an awful job of preparedness for an outbreak like this. I think there were some mistakes that added to that problem in the past couple of years.
Great, thank you. Other questions? And feel free to unmute your mic too if you want to just ask your question as well.
Yeah, and I'd love some comments from you who are at the front lines of this or are preparing to be. What lessons should we be learning from COVID about how to better use health information or better collect data, better train people to do the jobs that you're being expected to do?
Hey there, my name is Daniel Utek. I work down here in Dallas, Texas at Parkland Memorial Hospital. And I think some of the things that we're seeing is just the lack of communication, even within the state. Like, we couldn't report our COVID data just until today, electronically to the state of Texas. It was all manual entry by our infection prevention staff. And so I think, like, thinking back into the Bush era, meaningful use was supposed to help make that doable, right, but it didn't work. So I mean, I don't know if I have the answer, because I think oftentimes what I find difficult is getting people that we elect into leadership positions to listen. And I think that's kind of to your point earlier, is you have to make it a part of their agenda, but it seems to be tougher and tougher to get that to be a part of their agenda. So I don't know if you have any recommendations with respect to that either, but I think that was kind of one of the things that I find kind of mind-boggling, is that, like, since meaningful use, we still weren't able to report that kind of thing electronically to the state of Texas. And some of that was Parkland's fault. Some of that was the state of Texas.
And so you would have to double enter things, that your hospital system wasn't compatible with the system that the state was using. Yeah,
well, and the state didn't really have all the necessary things in advance either. So it wasn't just like our hospital, as other hospitals had other issues. So yeah, you had a human interface, typing over here, move over, type over here,
Yeah, and I remember in HHS, meaningful use was an important term having to do with what was private information and what you could share. If there was a meaningful use for that information, which was gathered for individual patients, it could be shared publicly. Is that understanding correct?
Yeah, and there were certain incentives that they had for reimbursement that were around putting together certain ways of capturing data and being able to share it, like you had mentioned.
But a huge issue in the Obama administration was that under the Affordable Care Act, electronic health records were a big deal, but there were multiple contracts let, so that the question of standardization of the information and of the input was done provider-driven things. These were providers selling systems to the government or to states or to individual facilities to meet certain standards. But the sense of for whom were these systems working was a huge problem, I think. And it sounds like your example is that this is not, if anything, gotten even worse with COVID. Anyway, thanks for sharing that. And be interested in other people if Minnesota has the same issues.
This is Linda Kloss, and I would just add that this underscores something that we know is a gap, and that's the link between the clinical information systems and public health information systems, which have never been adequately invested in. And whether that's public health reporting in general or something like this, or even morbidity, even mortality,
Right.
death reporting systems are known to be the weakest link. And I think this is just underscored that weakness.
Right, and I mean, you could say the US isn't Uganda, but in 2005, all the records were kept manually, pen and ink on paper. There were no electronic records. And the idea that you could move overnight to that was resisted by the people collecting the records. And they would then have to summarize those records in another handwritten document that would go to the county or district health authorities. But that was the way they worked. And I think that, yes, to automate that system was absolutely long overdue. But it turned out that US money was not enough to make that happen. You really had to get the people involved in the system to look at what their own needs were and how they could benefit from a much more improved electronic system. So this incompatibility is, we're not Uganda, but the same frame of mind seems to be it seems to be guiding policymakers who are making decisions which don't pay off.
Other insights that people want to share?
This is Tracy. Can you hear me?
Yes.
Yep. Okay. You can't see me in video because I'm at the hair salon, so I'm not putting myself on video. So, but just one comment that I just wanted to make with the electronic death certificate system. We have that in New York State, and I was tasked with getting the doctors to adopt it because, right, actually, the main camp at Stony Brook got a call from the Department of Health saying, hey, get Southampton on board because we really didn't adopt the electronic death certificate system. So they called the local village clerk's office, and she called me and she said, Tracy, can you help? And I said, sure. So we got the doctors, like enrolled in the electronic, death certificate system, like left to their own devices. These doctors are just picking whatever they think just to get through the screens. You know what I mean? It's not necessarily, like a thought process, because obviously when you see the handwritten death certificates, always the first diagnosis is always cardiopulmonary arrest. So, I think too, back to Linda's point too, it's just like the doctors middle of the night, they got to fill out these certificates, for the whole, funeral director process to kick in. They're just trying to get through, like the process. So not understanding the implications.
Absolutely. I mean, that was one of the lessons of AIDS. There was such a stigmatization of AIDS initially that no one wanted AIDS on a death certificate. And of course, immune deficiency means you die of something else. No one literally dies of AIDS because your any germ will kill you if you don't have an immune system. But it was very hard to estimate what the actual impact of AIDS was. And we've just seen a revision of that. I'm sure many of you saw this sort of meme that said, oh, there are only 6,000 people in the US who have actually died of COVID because they all had underlying conditions and they died of something else. And, no one died because the Titanic hit the iceberg. They all died of drowning or, exposure to cold. So, the underlying, the fact if the Titanic hadn't hit the iceberg, those people wouldn't have died is a way of thinking about what COVID's impact was. And that's why the difference between how many people have died this year, just in terms of total numbers of deaths compared to last year, is a valuable statistic because it's probably as accurate as anything else in determining what the actual impact of COVID is on our on mortality. Because many people are, you might have died of your cardiac arrest is going to be a factor. That's why you aren't alive anymore. But what caused that? Yeah. Did you solve the problem in New York? I mean, is there clear guidance to people making those entries in New York or?
No, no, really, like in the, so definitely, I think just going to an electronic, death certificate system, like help, there's like prompts through it, because when it was paper, it was just always like, you could see it on the paper copy. It was always like, the first was like, cardio, respiratory arrest. And then maybe there might be one or two, like underlying conditions. I think, like when I was training the docs in my hospital, cardiopulmonary arrest was not a choice, you know what I mean, to put it kind of guided them a little bit. But I'm thinking, as I'm showing, the docs, is like they figure out workarounds around, it's like any electronic system, it's they do it quickly, and it's electronic is probably helping along with giving them helpful hints, but there's definitely like more more help that probably could be invested in these, the electronic death certificates to, just get more meaningful data, because otherwise it's just the individual doctor's interpretation. So, and it was really interesting because I had to get the emergency room doctors to do death certificates for the first time. At my hospital, they were like, we don't know these patients. So the funeral directors would be running to the primary care physician to get the death certificate completed.
Mhm.
So it's interesting. Yeah. And I think that's was hard because like on the news, like that's where they were talking about, like, oh, the hospitals, coding the data, it's not correct. And, it's like, it's hard not to take it a little personally. So.
Mhm.
There's another question that came in the chat. The question is, the biggest issues facing the healthcare system is the lack of system integration. How do we get the health systems vendors to collaborate together to come up with a way that we can all, a better way of capturing and sharing patient data?
No, again, it's not my specialty at all, but I think we do have to be very conscious of how much the requests for proposals and the specs for some of these contracts that are let out by the public sector, including the federal government, but also state or local governments, are influenced by the providers, that they have, it's supply driven. If you have a system that can do X or Y, you sell the person writing the specs on the value of that, and they include that in their requests for proposals, and then the winner is the one who influenced the discussion. And I, if we were starting all over, I am getting a little bit political. If we were starting everything all over and we had no healthcare anywhere in the world, a single payer system with a kind of national standard for all of these things would make sense. But that's not where we are. And how we get from where we are to a system where there's greater harmonization, where these standards are discussed among states and especially among the payers. It mostly has to do with who's paying for the care and what the financial incentives for a provider or a hospital are. And we just need to do a better job. Both there are regulations that can be addressed, but everyone hates regulations because we're used to doing it the way we've done it. And unless you get the individuals who are actually going to collect and ideally benefit from the information you're collecting into that process, then the regulations are going to look like an imposition or a restriction on what they know how to do. So I don't have the answer to that. But again, I hope that you who are the professionals in this field will look for hacks, fixes that are going to make this a lot more integratable so that we really can benefit from the expertise that you have. Because I as a policymaker really felt the lack of, there was just too much uncertainty. There were a lot of things we just didn't know about, for instance, treatment of AIDS or treatment of Ebola, which had we known probably would have given us better results, at least in the initial stages. And figuring out what's the reliable data, who's collecting it, and how it's presented is not a straightforward process. Everything's a one-off. I see Linda Klaas is saying new interoperability rules should help. Have they? I mean, that was, again, this was one of Obamacare's goals. I was in that administration, so I have a prejudice.
The rules were just final. First two rules were just final a couple months ago, and now their implementation has been delayed. So I think it's still too early to know how much they'll move the system. But, they cover issue of blocking the cooperation among systems, and that's a start. And I would think that would be a public policy that would carry over to a new administration, since it started in the Obama administration. And it just finally, the first 2 rules rolled out a couple months ago.
I didn't realize it was still in process, but.
Yeah, it is.
Great. I don't want to take time from dinner, family, and other things, your own lives, which are already in progress, but I don't have a deadline. If there are more questions or people wanting to stay on, I'm around for a little bit longer. But David, what's the protocol here?
Yeah, we have until around 6 is what we scheduled, but there are, if there are any questions, feel free to ask and unmute yourself, or comments, or you want to share some experiences. Let's hear it.
Can we just, could you comment on going forward? If you were in charge of the COVID response over the next couple of years, what would you say would be the most critical steps that need to be taken? So looking forward a little bit, what advice would you give?
I think the attention to a vaccine and to countermeasures. Sometimes we've talked about the vaccine as a savior, and I just was on a very good webinar yesterday from the National Academy of Medicine and the American Public Health Association, which they had some of the people who were involved in Operation Warp Speed talk about the timetable. And it's a little bit more optimistic than I thought. About, as I say, we probably will have about 40 million doses, which would be 20 million individuals in the United States within the first month after FDA approval. And FDA approval could come as soon as early January. So the very highest risk groups could actually be covered in the first 3 months, and the general population by the beginning of the 3rd quarter of next year. So in terms of will we have Thanksgiving with our families next year, vaccine, to me, if that data is right, and of course there's some optimistic assumptions connected to that, but at least from the information we have so far, and if the optimistic assumptions prevail, yes, by this time next year, we probably will be able to have the vast majority of the population vaccinated with an effective vaccine. In the meantime, countermeasures are very important. I think we've underestimated what some of the steroids, monoclonal antibodies, the ability to save lives and to make the cases less severe for people who are infected. So progress on that should get attention. But there's no escaping that individual non-clinical interventions, behavior changes are essential, and including wearing masks, social distancing, indoor gatherings. Those restrictions are going to need to be in place for a while. And then the facilities themselves, with which all of you are much closer than I am, but our ability to judge when a facility is able to operate at effective capacity, when it's reached its limit, how we deal with burnout, how we deal with the fact that these facilities themselves are learning by going largely through trial and error, that we don't have a strong national message about exactly what our prioritization should be in terms of patient care, or admissions, or testing, or follow-up tracing, patient contact, hotspots at nursing homes, or places of employment, or prisons and other things. That the idea that we haven't really gathered that information, and there's no national voice ideally from CDC about that. So we have to do a lot of things at once, but definitely vaccines and countermeasures, definitely behavioral changes and consistent messaging about that. And then attention to how the red lights flashing in terms of care can be addressed by the larger society, the government, and the healthcare profession. Does that make sense to you?
It does. Thank you very much.
Another question came in. From your experience, what is the most important information needed to be accessible to transform public health policies? Do you see any change in policies coming as a result of COVID-19?
Sure, but we're fighting the last war. I think the sense of international collaboration needs to be reviewed. The role of WHO, the role of the labs in terms of what they share initially, and then the whole government structure. I mean, the idea that our COVID team, this task force, had never met before. I mean, they'd never exercised. And if we again look at what we do with the military, that how much of the time is spent in exercising and scenario planning and looking at mistakes we've made in terms of our training and how that's applied in practice. I think that fundamentally we have to do a much better job on the civilian side of replicating that in the health space. But that requires, I mean, that's even more time from the hard-pressed personnel that you're all either are now or are about to be. And the idea that we can just take off from our normal duties and go to a 3-month course where we're doing exercises is not the way hospitals work these days. So I'm not sure I have a practical solution. It does seem to me that the messaging from the leadership, the role of the Centers for Disease Control, the National Institutes of Health, and the Food and Drug Administration need to be reinforced, and that they should be the ones providing the scientific briefings on a daily basis and answering reporters' questions about the data. How did you come to you're recommending that schools can only reopen under these circumstances? What's the information you have to support that? What are the trade-offs? Why didn't you pick this other alternative? I think the scientists need to be able to answer those questions from people like you, and that data should be public so that you can second guess them or come to a different conclusion by analyzing it in a different way. But how we move from here to there, I wish I had a smart answer. I do think goodwill and this sense of relying on each other, thinking that we're all on the same team, is probably a prerequisite.
Good point.
Any other questions or comments?
David, is that a real scene behind you? Is there really that much snow?
There was a few days ago, but it was pretty warm today, Linda, so no longer.
It's very pretty.
We just had our first freezing temperatures in Washington, D.C. last night, so that was.
Well, I'm not seeing any. So on behalf of everyone at the college, thank you so much for spending this time with us this evening, Ambassador Kolker, and thank you to all of you for being here tonight. This is a great opportunity for us to put our minds together, work together in a virtual way, and maybe we can solve some of these problems that are so clearly apparent.
Yeah. I'll just say as a last word, it was really encouraging that you are looking internationally to see how the expertise that you've developed actually applies to different societies. I'm very pleased to see, just in the names that are on the gallery, some African names of people who are getting these skills and are going to, I hope, be applying them in their home countries. And that having a speaker like myself who's looking at the interface between information management and the kinds of decisions that diplomats and public health policymakers need to make is really I think a tremendous compliment to the program that you're developing. I wish there were other institutions that were looking at things this way. So congratulations to all of you.
Thank you so much. Thank you everyone for being here tonight, and we hope you have a very safe and happy holiday season. Thank you.